Good afternoon. My name is Tyler Whelan. I'm the Northwest Regional Manager for LivaNova. We partner with many epilepsy centers and neurology clinics to provide case management services for patients who are considering vagus nerve stimulation, or what you may have heard of called is VNS. VNS is a therapy for patients that can't control their seizures with medication and aren't pursuing intracranial surgical options. If you have any questions concerning VNS therapy, please don't hesitate to contact us. In my previous role with LivaNova, I had the pleasure of working with our next speaker as one of his VNS consultants. Epilepsy patients throughout Washington, as well as northern Idaho and western Montana, are fortunate to have him in his clinic. Dr. Timothy Powell is the next speaker and will be speaking on the topic of COVID-19 and epilepsy. Dr. Powell graduated from Wake Forest University School of Medicine and did his fellowship in epilepsy at the University of Alabama, Birmingham. He is a board-certified epileptologist and practiced for 20 years in Spokane, Washington. He is the director of the Providence Epilepsy Center at Sacred Heart Medical Center and is the proud recipient of the 2019 Purple Shoe Award given by the Epilepsy Foundation in recognition of his dedication and service to the Spokane epilepsy community. Please welcome Dr. Powell.
Okay. I hope everyone can hear me. Looks like it's going on my end. I'm Tim Powell. I'm a neurologist or epileptologist here in Spokane, Washington. I really appreciate the organizers for giving me this topic. It was very informative for me, and I think it'd be very informative for you as well, too. This is obviously a very timely topic, and so we'll just launch right into this. First, I want to give you a little bit of Virology 101. For you, actually, it's 0.001. There's some very basics about what a virus is. So all the virus is it's a capsule. It's a protein capsule that surrounds DNA. So it's think of it like a cup or a bowl with DNA in it. That's all it is. It's not a living organism. It has no metabolic energy producing capability. It can't replicate its genetics. It can't create energy. It can't do anything like that. It has no machinery. It's simply just a transmission, a vehicle, a protein. And so how does a virus survive then? Well, viruses are very stealth, very parasitic. They must have a host cell. And I want you to concentrate on that word right there. It's going to come up a couple of times. So there's a host cell. And what a host cell is a cell that has its own genetic metabolic energy producing. It can make DNA, it can process genetic code, it can assimilate nutrients. So what happens with a virus is they attach to the host cell, and then they can inject or put in their own DNA or their own MR or RNA to make their own genes. And so what's the difference between a bacteria and a virus, you might ask? Bacteria, they're living cells. They have gene-making ability. They have the ability to make metabolic energy. They have the ability to process code. They are living. They survive when they have nutrients, so they need food to function. They use these nutrients to produce the energy to run their genetic functioning, and so that they can perform their function, whether that be good or bad. They replicate on their own. They don't need host cells. They are their own thing. So really, they're like little people. And that's the difference between that and a virus. So bacteria don't need host cells. Viruses do need host cells. And again, the viruses, they have different shapes, polyhedral, spherical. That's what the coronavirus is like that. I love this one. It's called a bacteriophage. And what happens is the DNA sits up there in that area right there. The spikes, they attach to the cell, and the DNA is in here, and it injects the DNA right down that pathway right into the cell. And here's an electron microscopic view of that virus doing its job. So viruses are outside the cell before they attach to the host. And what they do is they come, and then their receptors on the virus, they attach to the receptor on the cell. And then that connects the two together. The cell membrane opens up, and then that allows the DNA from the virus to be injected in to the cell itself, the host cell. And that's where it starts to replicate and so forth. So A little bit about COVID-19. For those of you who haven't been paying attention for 10 months, I hope everyone knows this. I hope this is a review, but for the purpose of this talk, let's review. So what is COVID-19? Well, CO stands for COVID, VI stands for virus, D stands for disease, 19 is the year that it appeared. So COVID-19, the coronavirus disease 2019. It's also called SARS-CoV-2. A lot of you may recall the term SARS before. This is the second coronavirus causing SARS, severe acute respiratory syndrome. So how is it spread? Well, the coronavirus, there are many of them, but this one, it spread from an animal. They think it was a bat to a human at a China market in Wuhan, China. And then it gets transmitted from human to human through the respiratory tract. Either we breathe it in through our nose or our mouth. It gets into our system, and then it goes about finding a host cell. So when it goes into the respiratory system to begin with, it triggers the immune response. We've all had an inflammatory response when we catch a cold. You get runny nose, cough, sore throat, fever, muscle aches. All these are non-specific symptoms related to inflammation. And the coronavirus is no different. A virus enters in, and the inflammatory response kicks in, and then you start getting those symptoms to begin with. But then how does COVID kill? Why is it so deadly? What it does is it finds that host cell in the respiratory system. It inserts its genetic programming into the host cell. That host cell doesn't know what's going on, and it starts unknowingly replicating the genetic code, and it begins creating all these viral proteins that go thousands and thousands and thousands of times, and they start formulating themselves and assimilating themselves, and they create the virus. They create copies of each other. They build themselves off the genetics that the host cell has made for them. And eventually there's so much virus capsules in the cell that the cell wall will rupture and the virus will escape. Now you have thousands of viruses outside of that host cell. They go attack other host cells, and they inject their genetic material, and that host cell starts making more of the virus. So it starts the process again. New host cells eventually, they overwhelm the entire group of the cells specific to the organ that they're in, i.e., in this case, COVID, the lungs. So what happens is most victims, they die from complications, including pneumonia, a lung disease. You might get swelling in the pathways of the lung. What happens is with the swelling and the disease, fluid will just flood the lungs. And that swelling, what makes it happen is it's hard for the lungs to pass oxygen into the bloodstream. Therefore, you get organ failure and death because you don't have the oxygen to maintain what's going on in that organ. The blood also, this is new. I just read this about yesterday. I didn't know this. So this is new information for you as well. The blood becomes hypercoagulable. And what that means is that the tiny clots start forming in the blood, in the arteries, and those clots go to the organs, and then those organs get damaged because the clots block the oxygen from getting to the organ. Therefore, again, that leads to organ failure and death. That is how this virus works. This is why people end up on ventilators and why the illness becomes life-threatening. It's a very serious disease. So the purpose of this talk is what's going on with COVID and epilepsy. Well, we're going to start with COVID and neurology to begin with. There's not much published yet. If you know, I think we just have this virus since February when it came into Washington State, the first case here. And so not much is published, but what we do know is there are acute symptoms of the disease, and it's all related to the initial inflammatory response and then the initial creation of the virus from the host cells. The neurological symptoms, that's what we're talking about now, include headache, loss of smell. That's very interesting. It attacks the olfactory nerve, which is what interprets the stimulus from smells and odors and tells your brain what you're smelling. That gets damaged by this, so people oftentimes up front will lose their smell, which causes them to lose their taste. Confusion, dizziness, stroke can be an initial symptom of COVID infection. Neuralgia means painful nerves. So those are the acute symptoms that can show up when the initial infection starts. What about chronic symptoms? Well, we simply don't know that yet because it hasn't been around long enough. There's a lot of postulates about what's going on or what could happen, and a lot of this is based on what happened with other viruses that created neurological conditions and what happened to them down the line, what were their chronic symptoms. So things that we don't know, none of this is known yet, so don't be scared, but dementia, Parkinson's, chronic weakness, fatigue, other nerve damage like that olfactory nerve, and seizures. Could that be a chronic part of the infection? Well, again, we simply don't know yet. There's an article here, this was published in the Annals of Clinical and Translational Neurology, and they looked at 509 consecutive cases of patients in a hospital system in Chicago that were admitted, confirmed COVID-19 positive. And they looked at the neurological symptoms. So, and again, they're kind of really generic. Muscle aches, headaches, confusion or encephalopathy, dizziness, altered sense of taste, altered sense of smell. Those were the symptoms that were noticed in this group. You can see the percentages. A third of them had headaches, 16% had their taste affected. The neurological manifestations were present, and this is an important thing to look at. So I want to highlight this. So when the patient first got the disease, right when they were infected, the very first symptoms produced neurological symptoms in 42% of them. If the patient required hospitalization, 62% of them developed the neurological symptoms. And then at any time during the disease, whether that was before, during, or during recovery, 82% of people developed a neurological symptom. So the brain is highly susceptible to being affected by this virus in many different aspects. And that's what's scary about this virus, at least to me and to many other physicians as well in our field. So in this same group of 509 patients in this study, strokes, movement disorders, motor and sensory deficits, ataxia, which is unsteady gait, and seizures were, concentrated on this word, uncommon, which is good news for all of us. So 4 patients developed seizures, that's less than 1%. 7 patients developed strokes, that's 1.4%. So that's a low number, and that's just based on this one study. That's just based on these 509 patients who presented at this hospital. Now there's another study that talked about strokes, and let me get rid of all this. So this one is 1.4%. This other study, published in Neurology, was 1.8%. I couldn't tell from the study how many patients there were there. It was definitely over 100, but I simply don't know how many it was, but it was enough for Neurology to publish it, so it wasn't a small number at all. It wasn't 5, it wasn't 30. Anyway, this is what's scary about this. So their number is 1.8%. The other study is 1.4%. That's the same. But here's the part that I don't like. If a stroke patient ended up in the hospital, 1/3 of them died. So stroke symptoms right up front or during the active part of the infection can be very serious. Although stroke's rare, if the patient ends up at the hospital, which all stroke patients should, 1/3 of them are not going to make it outside of the hospital. That is an extremely bothersome number to me. Okay, what about seizures, which is what we're all meeting? Well, there were a few articles that I read, or that I found. One was in Epilepsy, which is the main journal for epilepsy. One's in JAMA, Journal of American Medical Association Neurology, another one in Epilepsy. And here's what these said. The first one, analysis of neurological symptoms in 214 patients where the outbreak started. They reported only 1 patient who had seizures out of the 214. That's very helpful. That's 0.5%. Then a summary of clinical evidence for neurological symptoms from 14 publications. Let me stop there just for a second. They didn't say in this article how many patients were involved in the 14 publications, but obviously this is going to be several hundred patients. And so of this review that these authors did of these 14 publications, it says this: only very few reports of new onset or acute seizures in patients with COVID-19. That's extremely encouraging to me too. Then there was a retrospective study. In other words, they had the records in the patient and they looked back in time to see what happened to the patients. They looked at greater than 300 patients diagnosed with COVID, so COVID positive, and they did not detect any seizures, new onset or acute seizures. Again, extremely good news for us, for me, for you, for this entire epilepsy population. So are seizures a symptom of COVID? Well, probably not, as we just talked about. Seizures do not appear to be a significant direct, I'm going to circle that word, direct symptom of COVID, but we do need more time. Now, are seizures a symptom of COVID-19? Well, possibly so, because the late stages of COVID may affect the brain. I already talked to you about that. We don't know about this yet. It's still to come. But the stroke, the inflammation, the hypoxia, which is lack of oxygen, can that all lead to damage to the brain tissue, which can therefore lead to seizures? Of course. We don't know if that's going to happen or not. All I can say right now is the acute infection does not appear to cause seizures or to worsen seizures. So Can seizures get worse though if a patient gets COVID? Well, not the direct effect, but they certainly can get worse from indirect effects. Can seizures get worse if a patient catches a cold? Well, of course. That's one of the questions that we ask when you call us. Are you sick? Are you ill? Did you miss any pills and so forth? Because that can trigger seizures in someone who's already susceptible to having them. Nausea and vomiting, if you're throwing up your pills, of course, that's going to present a risk for having seizures. This thing that I put here, 30-minute rule, that is totally my own personal thing. I don't find it written anywhere. I don't know any science behind it. It's just what I tell my patients. So if someone takes their pills and they throw up within 30 minutes, my feeling is that the medicines didn't make it in the system, and I tell them to take their pills again, just as if they didn't take them at all. If it's beyond 30 minutes, we kind of play the game to decide, should we take an extra pill or not? And that's kind of patient-specific, depending on how severe their epilepsy is and based on what medicine they have and what time of the day they took it. But that's just my rule. Fevers obviously can lower seizure thresholds as well, which can then allow a seizure to occur. There was stuff when it first came out that it was dangerous to use, get rid of all that, dangerous to use ibuprofen in COVID positive patients. That has been debunked. It is okay to use ibuprofen now if you have a fever or muscle aches and so forth from infection. So don't worry what you might have heard 8 months ago. That is no longer the case. So all this stuff has to do with thresholds. And I want to concentrate on thresholds for a little bit. It's extremely important. So what a threshold is there's an electrical potential in the brain that the potential of the energy of the brain, the electricity of the brain has to build up to a certain point. And when it reaches that threshold, then the nerve cell will fire off and it activates and it does what it's supposed to do, i.e. I need to move my arm. Well, it reaches up here and then it'll let me move my arm. And so that threshold has to be met before the brain cells will fire off. Well, in patients with epilepsy and seizures, that threshold is low already. And so you want to do what you can to increase the threshold to keep the brain from firing off on its own. So in patients with epilepsy, if the threshold is low and they don't have any way to protect that, the brain's going to fire off the seizures because it can reach that threshold very easily. And so this is an example over here of an EEG. Here's a patient. This is the EEG. He's asleep. He or she's asleep. Everything looks fine. And then all of a sudden, right there, the threshold dropped. And what happened is the patient went into a seizure. So all those things out there are seizure discharges. So you can see right where that threshold dropped, right at that port right there. And this is what you're trying to prevent from the brain being normal to abnormal. Don't drop your thresholds. So examples of things that can lower thresholds, and this is very important. If you don't hear anything else I say today, please listen to this. Missing doses of medicines of seizures. That is the first question you'll be asked if you call our clinic and my staff talk to you. Did you miss any pills? The second question we'll ask you is, did you miss any pills? And the third question we'll ask you is, did you miss any pills? And that is the strongest part of things that can lower seizure thresholds, is missing your medicines. Stress, a lot of people say stress causes my seizures. I want to dissect that just a little bit. Stress doesn't cause seizures, or I would have seizures, and so would every person in this world. But what stress does is it lowers the threshold. And so in individuals who don't have epilepsy, their threshold's high, and they're going to stress, the threshold will lower, because that's what stress does, but it doesn't drop to the point where the brain can go into a seizure. Whereas someone who has epilepsy, the threshold's low, and if it drops because of stress, that might let the seizure happen because the brain has lost its ability to protect itself because the threshold dropped. Sleep deprivation, fever, we've already talked about. Alcohol use. Alcohol is a double-edged sword. It can drop your threshold when you're taking it in. You can also withdraw from alcohol when it's leaving. Alcohol is a bad thing. We'll talk about that some other time. And then there's medicines that can lower seizure thresholds as well. There's many. Many of our patients, they'll call us, say, my doctor would like to put me on this medicine. Is it okay? And we love those phone calls because, first of all, they're easy to answer, yes or no, but it also helps us to know what's going to happen with the patient if they take the new medicine and so forth. And it also gives the patient some reassurance that what their doctor gave them is safe for them to take. So other medicines can lower thresholds. They did a survey, the American Epilepsy Society did a survey of 337 epileptologists. This was just published a month ago, and it's on the American Epilepsy Society website. Of those 337, they interviewed them and asked, how many of you have been seeing an increase in seizures in your patients? 30% of them said they had, but here's the thing, all of them, nearly all were associated with lowered seizure thresholds. So you cannot ignore this concept about thresholds. All right, missing medicines, I've already talked about that. It's the strongest cause for lowering seizure thresholds compared to everything else. There is no excuse for missing medicines. Well, unfortunately, there might be a rare excuse, but that is the exception to the rule. It is so important. We don't have a lot of margin for error with our epilepsy. And we miss medicines, that'll drop that threshold, which will make it easier to go for the brain to go into the seizure. That's what medicines do, actually. Medicines increase the threshold. So that's why you take them, is it pushes that threshold up. That way it protects the brain from going into the seizure. So I did a search on, I have an iPhone, and I just typed in medication reminder apps. Well, I'm sorry, first this slide. All right, so what's your game plan? You need to come up with some way that you will not forget to take your pills. So some people use a pill box. I guarantee if I had to take medicine, I would have to use a pill box. The only way the pill box doesn't work is if you don't fill it up Saturday night. Fill up your pill boxes on Saturday night. Phone alarms. So a lot of people say, oh, I set my alarm, but then they ignore them. Don't ignore your alarm. What about the pesky dads, the moms, the siblings, the friends? Don't ignore them. Don't do this. Just understand that those two people love you to death. They care about you, and they feel very helpless when they're watching you have a seizure. Keeping a log or a list. I have a couple patients who really like graphs, and sometimes patients with temporal lobe seizures are that way. They'll keep graphs and logs, and they'll bring them in and show them to me, and I appreciate them doing that. Here's an easy one to me. Brush your teeth. Well, we always brush our teeth twice a day. When you're doing it, you've got water in your mouth anyway. Take advantage of the opportunity. Take your pills when you have water in your mouth. So that's twice a day dosing. Brush your teeth morning and night, and you'll have your pills. Everyone usually eats breakfast and dinner, usually. They usually do it every day. So I'll tell the patients, you are not allowed to eat until you take your pills. And that's how they remember it. And come up with your own habits. Invent something yourself. Some people will flip the bottle. I like this. I actually have a lot of patients do this. So put the bottle up in the morning, and the cap will be on top. They'll know they didn't take their pills. They'll take the pills. When they take the pills, they turn the bottle over upside down. They leave it there. When they go to bed at night, they see the bottle's upside down. They know they need to take the pills. They take the pills, and they turn it back up. So they do this bottle flip every day, and that helps them. And then the phone apps that I was talking about. So these are just screenshots of phone apps that I found. They all have advantages, they all have disadvantages. Just take a look. You'll find one that you like. They're usually always free, but use them. All right. Some people have asked, is there a concern about not getting supply of medicines into the country because of the COVID stuff and the shortages and all that stuff? The FDA is monitoring that very closely. I promise you that. They have told us that they will let us know if there's any concerns. There have been no shortages reported due to COVID at all. So all the seizure medicines have been safe. There's good supplies. Now there's some supplies of Keppra that are still low. That is a Keppra thing. That is not a COVID thing. So don't worry about that. There's nothing new. Insurance companies will sometimes relax their rules, so they might give you more than a month's supply. Now you'll just have to, your doctor can write a 1 month, 2 month, or 3 month prescription at most, and then see what the insurance pays for. Mail orders are used a lot more now too, because people are not leaving home. Okay, next slide. Okay, we talked about COVID and seizures. How about COVID and epilepsy? Well, there's no direct risk of epilepsy worsening, just like the seizures. Everything's fine. You are not more vulnerable to becoming infected because you have epilepsy. You are not. Your typical seizure medicines do not put you at risk of infection because they don't cause immunosuppression. The ketogenic diet does not put you at risk for getting infected. Now, the immunosuppressives, there are a couple that can do that. For instance, everolimus, Dr. French just talked about that one for tuberous sclerosis. It is an immunosuppressive, and so those individuals on that may be at slightly more risk. I have a few that take that, and they're kind of staying home. They're strictly quarantined because of that. But for the most part, everything about your epilepsy, your medicine, is not a significant concern related to getting infected with the COVID virus. Okay, the thresholds in epilepsy. So the same thing, I cannot stress this enough. Missing medicines can worsen your epilepsy, fever, stress. Things you can do about stress during this time, we're all kind of locked in and we've lost touch with friends and things like that. Some stress reducers, relax, read, music, yoga, do something you enjoy, get outdoors if you can, stay in contact with others. I personally do not like the term socially distanced. I know it's used, I'm not going to change it. I keep saying it, but I would rather say physically distanced. It's the same thing. I think we need to be careful about losing our social aspect of our life during this quarantine. So I would say physically distance and not socially distance, even though the meaning is the same. Follow your state laws, and counseling also can help with the stress. So here's a summary. I'll read this the way it was in the article, and then I'll put it in English. It's kind of a little convoluted, but it says, it remains impossible to conclude whether seizures described in the context of COVID-19 were unprovoked seizures occurring regardless of a causal association in patients with an increased seizure susceptibility, acute symptomatic seizures occurring as an indirect consequence during a severe disease course, or acute symptomatic seizures linked with an actual neuroinvasion of the virus. All right, in English, what it says, it's impossible to conclude whether seizures occurred because you have epilepsy and you're going to have a seizure anyway. If it was an indirect cause, such as fever, and nothing to do with the virus, it was an immune response, an inflammatory response, or if it was because the virus had neuroinvasion into your brain tissue itself. So right now, we don't know. And that's all that paragraph is saying. All right, so what's my experience? So far, I've had 10 patients who have tested as corona positive. And those are the ones that I'm aware of. I guarantee you there's a lot more than that, but these are the ones that I'm aware of that I've ever heard through the phone or from seeing them in clinic. 2 of them have died. 2 were really ill and they were hospitalized and lived. 5 had nonspecific inflammatory symptoms such as the headache, the fatigue, the muscle aches. 2 of the 5 had the loss of the smell and taste. They both recovered it. It both came back. 1 was an asymptomatic carrier. She was tested only because her husband was tested and found to be positive. So they had to test her. She was found to be positive. She never had any symptoms at all, which makes that one a little bit dangerous because she doesn't know she has it. It's not her fault. She doesn't know, but she's out and about. If she's not trying to protect herself or protect other people, then she may be spreading that virus. That's what the concern is there. Now, of those 10 patients that I talked about, none of them had reported a change in the frequency of their seizures, which again is good news for all of us. So stress. Stress is an independent precipitant for triggering seizures in some patients with epilepsy. You all know that. Again, thresholds, that's what it does. There's negative effects of stress during this time and under this pandemic. We've lost our routine. We're feeling out of control. We don't have some freedoms that we usually have. We're bored. We're coping in wrong ways, going to alcohol, going to drugs. There's a lot of anxiety about what's going on. We're missing people. We're not staying in contact. We're socially distancing. There's loss of work. There's loss of worth. I have a gentleman this week. I felt really bad about it. He was just crushed because the business he had, they had to close when all the COVID stuff started coming on. So he got another job with the oil industry and they had to shut down their plant. So he lost 2 jobs in a matter of 6 months and then had to file bankruptcy. I felt terribly. He felt just dejected. He felt loss of worth, and this is going on. So what are positive things that you can do that can help mitigate stress? Well, develop new habits, paint, knit, read, write, do something new. Indoor projects, there's a lot that can be done. I put cleaning the garage here. It's kind of a funny story. This is not my garage, I promise. It's just something I stole from the internet. But my wife got furloughed for 2 months at the start of all this. And so I'd come home and a new room would be painted or something been done, or all of a sudden the garden was completely planted. Well, I came home one day and she was cleaning the garage, and I knew it was really bad at that time. If she stooped to the low of cleaning our garage, then she must have been very bored. So, but anyway, it gave her something to do. Research facts. Don't research hearsay. Use trusted sources. Don't talk to my brother-in-law. I'll tell you that right now. Reconnect in different ways. Social media, video calls, renew friendships, stay in touch with family. Just physically distance. Don't socially distance. All right, so what about safety and protection? A lot of this will be common knowledge for you, but again, for those of you who have not been paying attention for 10 months, this is also for you. So how capable is COVID-19 with its ability to spread? It is extremely capable. It is highly contagious. The virus spreads mainly from person to person through our respiratory system, from the respiratory droplets. You know, when you in the wintertime, when you breathe, when you see your breath, those are respiratory droplets. That's how much we breathe out all the time. Just think about it in winter when you're walking around and do that. That with every single breath is what we're doing. Obviously, this guy's sneezing. We don't do that all the time, but the droplets do leave from talking, singing, coughing, sneezing. The virus inside these respiratory droplets. The respiratory droplets are not the host cell. It's kind of the thing that holds the virus and how the virus gets around through the air and then can affect us, it can survive 3 hours inside that respiratory droplet. So outside the body, it can survive. It can maintain its ability to infect host cells depending on where it's at. So if the virus is sitting on paper or cardboard or fabric, it can stay there for 24 hours and still be viable. If it happens to attach to a host cell, it still has the ability to inject this DNA and start the whole process. What if they're on hard or shiny surfaces, such as countertops, glasses, the handles at Albertsons, whatever? It can survive up to 72 hours. This is why they're supposed to get wiped down between every patient. This is why the clinic gets wiped down. This is why everything else gets wiped down around town. These things, when they sit on shiny surfaces, can last 72 hours. The virus can sit there. So if someone 3 days ago who used my shopping cart, I can still get the virus from then if that arm, the holder handle has not been cleaned off. So how do you prevent COVID from spreading? Well, quit giving it a host. So how do you do that? Well, don't breathe, don't talk, and don't touch anything. That will solve the problem. It's kind of hard to do that. We all breathe, we all talk. I'm talking right now. We all touch things. So how do you try to mitigate that? Well, don't breathe. So cover your mouth and your nose. Wear a mask. The main purpose of the mask is that it lessens the risk of you transmitting the virus. And as we know, many people, I promise you, there's someone listening to this presentation right now who has the virus and does not know it. You wear the mask to protect others. The secondary purpose of the mask is it can protect you, of course, but the main purpose is to keep everyone else safe. That's how you, quote, don't breathe. So what about don't talk? Well, that's the physical distancing I'm talking about. So the 6 feet away, I'm going to show you a picture in just a second about this, but that makes a difference. Why is that? Because it has been shown that respiratory droplets, when breathed out of the mouth, even sneezed out of the mouth, does not transmit beyond 6 feet. That 6 feet isn't just made up, that's a real number. And so that's how you, quote, don't talk. And then don't touch anything. Well, wash your hands frequently. When I'm seeing patients, I desanitize my hands before I leave my office. When I get into the exam room, before I touch the patient, I do it. After I touch the patient, I do it. When I come back to my office to get the next chart, I sanitize my hands again. So with every patient encounter, I'm doing that 4 times. This was a really kind of interesting thing. This is one of our microbiologists here at the hospital. He just happened to do this, and this actually received a lot of press. I hesitate to say this, but it kind of went viral. I know that's a bad joke, but anyway, what he did is he held an agar plate, which grows bacteria. It has nutrients for the bacteria. He held it a foot away from his face, and he did 4 things to that agar plate with a mask on, and he did 4 things without a mask on. And what he did is he sneezed, he sang for a minute, he talked for a minute, or he coughed twice. So when he wasn't wearing a mask, the droplets that spread out from his mouth, not wearing the mask, hit the agar plate. And these are all bacterial colonies that are growing on this agar plate. And as you can see, sneezing was kind of the worst there. Now, that's the bacteria. The virus will be the same thing. Virus won't grow on the agar plates. Remember, they don't need nutrients. They need host cells. There's no host cells in the agar plates. Those are just nutrients for bacteria. Anyway, so he was masked and he did it. Not a single bacterial colony showed up on those. Same distance from his face, sneezing, singing, talking, coughing. This is how it was shown there by him in his little experiment that masking made a difference. Then what he did, he took it a step further, and he took these agar plates and he put them 2 feet, 4 feet, and 6 feet away. And he did one with a mask on and one with a mask off. And what did he do? He coughed for 15 seconds in a row. And with a mask on, there was one tiny colony right there, that little white dot, that made it 2 feet. But the 4 feet and the 6 feet did not have any growth. When you put the mask on, what happened was the 2 feet, you saw all those bacterial colonies show up, 4 feet, and then one made it 6 feet. And so I thought this was, it's not going to be published in the Journal of Neurology, but I thought it was a nice little demonstration. It did get a lot of press that shows that, hey, socially distancing and masking make a huge difference. Okay. I totally stole this picture from the internet, so don't tell on me. But it shows no masks, 1 mask, and 2 masks over there on the right side. Now, a lot of people say that this is the whole debate, that the virus is smaller than the mask, so it can get through the mask. That is absolutely true. The virus is smaller than the mask, and the fibers, it can get through. It's impeded, it's hard to get through, but here's the thing to understand. That virus isn't floating around in the air. That virus is inside those respiratory droplets. And those respiratory droplets are what get blocked from getting through the mask because they're bigger, and they also get attached to the front of the mask because it's cloth or whatever. And then it makes the virus harder to get in because the mask has stopped it. So it does a good job of preventing the droplets from entering and leaving the mask. Is it 100%? No, it is not 100%, but it is highly effective. Now, if you look at this, that person has a mask on, that person has a mask on. Can you see the little puff of the respiratory droplets to get out? So even with the mask on, this is a cloth mask. This is not the N95 ones. There's still some to get out. True, I told you it's not 100%, but look, they're 6 feet apart. Those respiratory droplets are not making it. So by masking and social distancing, physical distancing, it's going to make a difference. It does work. All right, so who should be tested? If you have COVID-19, if you have symptoms of COVID-19, automatically you should be tested. If you've been in close contact with a person, now the CDC, they define close contact as being less than 6 feet for a total of 15 minutes or more of a COVID positive individual, you need to be tested. Before you come in the hospital, for any procedure or any testing or things like that, you are being asked to do a test prior to getting in the hospital. Some work situations like staffing in a nursing home, they're asked to undergo tests. And if there's times where there's outbreaks, the public health officials in your local area will say, we want all these people to be tested, or we want all people age 60 and above to be tested, or whatever. So those are people who should be tested. Treatment. All right, there are greater than 200 candidates for vaccines being looked at right now. And so far, nothing has been shown to be effective. There's a lot of research, there's a lot of progress. Things are looking good, but nothing yet has come forth to say that this is going to be a good vaccine. And I'll give you a little heads up that the vaccine, probably the initial vaccines are going to be good at lessening the symptoms, but not totally lessening the infection. If people still get infected, then their symptoms will be less, but there's less people being infected as well because of the vaccine, and therefore be less spread. So it's going to be a stepwise improvement. It's not just going to be suddenly the world is a better place. For medications, there's only one medication that so far has received approval. That was in October. It's remdesivir. It's an IV antiviral agent. It's not an antibiotic. It's not going to kill bacteria. It's only going to work with this virus. And it's a 5-day treatment. It only is an IV. It's not a pill. Let me tell you how it works because it's kind of cool. What remdesivir does is the host cell, there's that thing again, the host cell takes up the remdesivir into the inside of the cell. That's where it's creating all the viral DNA. So the DNA has been put in there, and the host cell is saying, okay, I need this to make the DNA, I need this to make the DNA. It thinks that the remdesivir is something that you use to make DNA. So it grabs the remdesivir, puts it in the genetic code, and keeps making the genetic sequencing. Then when the ribosomes and all that stuff go to interpret the DNA and start making the viral proteins, it gets up to remdesivir, which was supposed to be a normal DNA building block, and it isn't. Therefore, the replication of the DNA doesn't work, the virus isn't made, and therefore you don't replicate it. So basically, it not hides, it just tricks. It tricks the body to think that, hey, you need me to make DNA, but guess what? I'm not what you really need to make DNA. I'm gonna mess you up. So that's how that works. Now, we talk about, all seizure medicines have interactions with drugs. Here's the issue with this one that I found is that some of the seizure medicines are called enzyme-inducing medications. They are tegretol, carbamazepine, Dilantin, phenytoin, topiramate, Topamax, and phenobarbital. Those are your enzyme-inducing medications. Those drugs, the enzyme inducers, if you mix them with remdesivir, they may decrease the efficacy of the remdesivir. So if our patients with epilepsy get sick and this drug's improved and they use it and they're on tegretol, phenytoin, topiramate, whatever, we probably should let the doctors know they're treating it that, hey, they're on a drug that may lessen the efficacy of this, and maybe you need to use a higher dose or you can't use it all. I don't know yet. It's not known yet. That's just the only drug interaction I could find so far with this antiviral that has now been approved. All right, so here's my closing points. about what we've talked about. So first of all, the neurology review. So there's acute neurological symptoms, which would be headache, confusion, loss of smell, and stroke. There are chronic neurological conditions. There will be chronic neurological conditions. We don't know what they are, still to be enumerated. The postulates and the suspicion, as I talked to you earlier about, is there nerve damage, chronic weakness, fatigue, dementia, seizures, all this stuff we don't know yet. Okay, what about epilepsy and COVID? The conclusion here. People with epilepsy are neither more likely to be infected by the coronavirus, nor are they more likely to have severe manifestations of the disease because they suffer from epilepsy. There is not a direct effect on seizures and occurrence in epilepsy, i.e., it does not look like the virus can directly trigger seizures in a patients with risk for seizures or epilepsy. There likely will be secondary or indirect effects on seizure occurrence in epilepsy. We'll see how that comes. I pretty much promise you that'll be there. Thresholds, do what you can to protect yourself. Don't lower it. Decide on your game plan for medication compliance and work on your stress. This is a stressful time for everyone, all of us, me, my family, my staff, everybody, and the patients, of course. And so try to find stress relieving opportunities. Here's some general points. There's a ton of mixed messages out there. Eventually COVID-19, it'll be a seasonal infection just like the influenza is, but probably not for a year or two. We're gonna be in pandemic stage for a while. I'm not a prophet, I don't know how long, but it's gonna be months. It's more infectious than influenza. It's more deadly to those that get sick from it. And the numbers show us that. Like the flu, there will be some who are asymptomatic or only have mild inflammatory symptoms, like my patients that I was telling you about. But unlike the flu, there seems to be a higher potential for long-term effects, even in asymptomatic carriers. What that means is that if you get the infection, and even if you don't know it, that you had it, you're asymptomatic, you still might have chronic neurological effects from getting the infection. Extremely serious, scary point. Okay, I think I'm coming down to my last, okay, here's my closing thoughts. These are my words. And I personally researched these numbers, so I know they're correct. In 34 collective years of global wars, the number of USA citizens that were killed in World War I, the war in Iraq, the war in Afghanistan, the Vietnam War, and the Korean War together totaled 220,000 people. In only 10 months of the COVID pandemic, the number of USA citizens that have been killed totals 235,000 people with no end in sight. This perspective is humbling. It's appropriate to identify our current health crisis as a war, albeit being attacked by immune systems instead of by bullets. If our country remains divided on this and only part of the country accepts their responsibility to follow basic science and care about the survival of all of our citizens, this war then turns into a civil war. Let's do our part to avoid the ongoing killing of others, surpassing the number killed in the original Civil War, which in the future might be referred to as Civil War I. Do your simple part to keep yourself and others from dying. The science is not hard to understand. Accept it and follow recommendations of scientific experts, not emotions, not ignorance. It's the right thing to do. This defense will work. I promise you that. And that is all that I have for you.
Thank you, Dr. Powell. Chris, we might have a few questions, I believe.
We do. Thank you, Dr. Powell, again as well. A couple of your points had brought up some questions, and I just want to get right into it. You had mentioned that the typical anti-epileptic drug does not increase the likelihood of COVID. Are there any meds at this point that do, or that we might have some information on pointing to them doing such?
That's a fantastic question. Thanks for asking that. Yes, the immunosuppressives, so the steroids, chemotherapeutic agents, drugs for antibiotics, things like this, can make it a little more likely to do that. So if you just remember that one word, immunosuppressants, those are the class of drugs that may put you at higher risk. Good question.
Thank you very much for it. Leading on to the last one here, how many strains, if you have it off the top of your head, I know it's changing a lot, of this virus are there that at least we now know of? And could you speak on that in any types of ways of actual transmission or specifics towards transmission in individual environments that may increase it or decrease it?
Okay, well, that's a complicated question. There are numerous coronaviruses. This is not a unique virus at all. It's just this one happens to be mutated to the point that it's highly infectious and can cause serious disease to human beings. A lot of the coronaviruses stay in the animals. They stay in that population. They don't transmit to humans. But yes, there are many, many coronaviruses. Chris, what was the second part of that question?
You actually just touched on it in a sense that actually this individual was looking to discuss. Do you have any information on the specific transmissions, such as at mink farms, when in concern to animals or any kinds of things like that in frequency?
Yeah, thank you for asking. I will plead ignorance on that one. I don't. All I know is don't eat mink, don't eat bats, but no, I'm just making that up. I seriously don't know.
Thank you very much for that. That concludes the majority here. So thank you for the time in addressing those.
You bet. All right, thank you.
And thank you everyone for joining us again. I hope we see you tomorrow. Tomorrow at 10 a.m. Pacific time, we are going to have a presentation on telemedicine with Dr. Edward Novotny. So I hope you join us. And thanks again to our speakers and our sponsors. Have a wonderful night, and we'll see you tomorrow morning. You'll use the same link tomorrow that you did for today. Thank you.